Hello and welcome to Medisch Kompas, the leading medical podcast from the Netherlands. I'm Christiana. Today I'm with Henry, and today we're with Dr. Claire Fuller. Dr. Claire Fuller took up the post of National Medical Director on the 1st of April 2025. Her portfolio covers primary care, community care, and mental health, as well as neighbourhood services, public health, and medicines. In July 2025, she became the higher tier responsible officer with responsibilities for performers list and professional standards. She qualified from St. Mary's Hospital in 1992, and throughout her career has remained a practicing GP with experience ranging from single-handed rural practices in Northumberland to large practices in Surrey. In September 2023, she was appointed as a primary care medical director for NHS England. Prior to that, she was the CEO for Surrey Heartland's integrated care system, having held executive system leadership roles in Surrey for a decade, starting as a CCG chair before transitioning into accountable officer and CEO positions. While CEO, Dr. Fuller implemented the vision for integrated care within Surrey. Since joining NHS England, Dr. Fuller has prioritized improving GP retention, developing neighbourhood health models, improving the interface between primary and secondary care, improving the awareness of patient safety issues within primary care, and the creation of a network of GP leaders across England. Welcome.
Thank you.
Yeah, indeed, welcome. And I would like to start off really with a question about your background and the path that you took. Could you give us a sense of what it was like from medical school through to really now, and how the decisions you made shaped your path into this career?
Yeah, so I'm a third generation GP. So my grandfather was a GP in Peterborough during the war, and was involved in the birth of the NHS. My aunt was a GP in Ely. And I knew from about the age of 12 I wanted to be a doctor, and actually always wanted to be a GP all the way through medical school. I was never really interested in one subject enough to envisage spending my whole life just talking about gynecology or just talking about hips. So was always destined really for general practice, and would make the same decision again. I mean, it has been a fabulous career, which has been incredibly flexible actually. But I'd never had any leadership aspirations. I was always going to be a GP, full stop. But sort of life gets in the way and things happen. And so what I'm trying to say is it wasn't planned. It was happenstance and a series of events that I've end up here.
You say, okay, I was born to be a generalist.
Yeah.
You practiced.
Yeah.
And now you take a less clinical role and a more organisational or vision role. Is that just serendipity?
Well, so I've always done every role in exactly the same way. So I think as GPs, I think we are incredibly good at receiving huge amounts of information in a very short amount of time. If you see somebody walking into your consulting room, you're already pretty clear: are they sick? Are they not sick? Are you really worried about them now, or can it wait? You've probably, if they've come with somebody else, you know that somebody else is really, you absorb so much information just by watching people walking into your room. You then analyse what they're telling you in the context of their lives and in the context of the record you got in front of you. So we're really good at absorbing complex information that we don't even know we're doing it. We then prioritise need, can then sift, again, without knowing we're doing it, what is the thing you've got to rule out. So the best analogy I heard anybody say was that if you're at home and just suppose you've got a swimming pool in your house and you call your child and you don't get a response, so the likely chances are that your child is sitting in the room with headphones on playing music too loudly and they don't hear you. But the first thing you do is you go and check the swimming pool, because actually if they're in the swimming pool, that is the irreversible thing that you have to fix. So, and I think that describes me what being a GP is about. So you go through, somebody walks in and you make sure that this isn't something catastrophic that you've got to do something about. Make sure not a cancer, make sure it's not somebody that needs to go into hospital. Once you've done that, you can then sit back and then you can actually go, okay, so how are we going to organise your care? So and that's how I've approached all my leadership roles. So actually, again, if you think in meetings, compared to doing a GP surgery where you can have, 20 people coming in, you don't know what's on the agenda, you don't know what they're going to talk about. You make that, at least when you turn up for a managerial meeting, you've got an agenda, you know who's going to be there and you know what we're going to talk about. Well, that's quite easy, isn't it? And people then say, you've got to have difficult conversation with people that are going to bring conflict, but you're never going to have to tell someone they're going to die. You're never going to have to tell someone that their children are dead. You're never going to have to tell someone the worst news they're possibly going to have. So actually, how difficult are these conversations really? So I think both as doctors and particularly as GPs, I think we're incredibly well equipped through our training and our experience to be leaders of complex health systems.
It's very interesting how medical education is more of a forming as a human being and acquiring all these skills that can later be employed.
Yeah, so and I also say to people, it's like, oh, I want to be a leader, what should I do? And it's like, do your job, be really good at your job, and go and see lots and lots of patients, because all leadership jobs are really based on that one-on-one interaction, which actually as a doctor, as a clinician, that is what we get better at than anybody.
Yeah. So you propose that in leadership roles, it's essential to be on the front line.
I think you've got to have done it. I think it just adds that credibility. It adds that credibility, but I think we undervalue the stuff we learn on the front line. I think that's been my really big learning. I think clinicians going into leadership roles think, oh, I've got to learn, I've got to an MBA, I've got to, and we don't understand actually the really powerful skill set we've got, which is dealing with people at their most frightened and anxious, and we are there to hold them and guide them through. Well, that's an incredible skill.
Okay, so we're here with you as the NHS Medical Director, and it's nice to start with an overall introduction of what the system is and what the pressures are of the system at this point in time.
So we had a new government came in last July, and one of the first things our Secretary of State, Wes Streeton, did was to ask Lord Darcy to do a review of the state of the NHS. And one of Wes's first statements was, the NHS is broken. Lord Darcy's assessment was that actually the situation is critical, but there are things we can do to save it. And I think his report, if you haven't read that, that's the thing I would start off by reading. I think it's an absolutely brilliant piece of work. And actually it talks about the damage from the Lansley reviews, about the fragmentation of the NHS and the introduction of multiple arm's length bodies and the fragmentation of the governments around how we do it and the separation from government. It also talks about how we've over-invested in hospitals and have become too specialised, and we've lost. So we put far more of our money into specialist services than we do into primary and community services. And we have not invested in the estate or in the infrastructure. We've also lost our focus on listening to patients and lost the emphasis on quality. So the 10-year plan really is our response to the Darcy report. So I think you have to read both of them in tandem. And if you look at the 10-year plan, and I led one of the work streams going into it, it was the largest listening event the government has ever done ever. So engaged with frontline workers and with members of the public over multiple months, and synthesised all that information really to make sure we understood the things that matter to both the professions and to the public. But again, if you do the word cloud of the plan, the things that come out are patients, quality, genomics, app, and neighbourhoods.
Okay, well, I think that's a good starting point if we then now take the time to dive into the three big shifts that we're going to have. If we could start with then, as you said, the shift from hospital to community care. Can you give us a sense of the substance and the essence of this, of this, and what you hope to achieve? What's the goal behind it?
So we've been talking about this shift from hospital to community. So I used to think the first time anybody was doing it, the earliest time was 1963. Somebody told me this week that actually there was somebody talking about it in 1958. So it's like, so we've been talking about this for a very, very long time. And we've got some absolutely brilliant examples around the country of people that are working in an integrated way, delivering personalised care consistently, but it is not whole spread across the country. So when we talk about neighbourhood services, when we talk about the shift from hospital to community, essentially all we're saying is we've got to make it easy for people to access care when they need it. And we've got to make it easy for professionals to deliver care. And actually the fragmentation of the health service has made it so complicated that, and anybody that's got a relative with complex needs will understand just how hard it is. So one of my drivers for going into leadership was my father has multiple long-term conditions. I remember he was in hospital, and actually it took most of my intellect to work out where he should be when, and to stop having multiple tests repeated and being sent all over travelling large distances, was a real understanding of the fragmentation of the system was required.
Sorry to interrupt, but when you say fragmentation, what you essentially are referring to is that different services exist in different entities.
And you have to do a referral form to them between professionals. And that means then there are thresholds for acceptance of that referral. And every time you do a referral, a patient can get lost or and it's a delay in a pathway.
And what I'm hearing right now is that we prioritize the easy access to the care. There are also other pillars in care, like having a specific doctor that you're always referred to and the continuity of care. How would these things be safeguarded? Yeah.
So continuity of care is the thing that is probably the most evidence for improving, decreasing mortality, improving outcomes for patients, and actually improving, particularly in general practice, workplace satisfaction. It's when I trained, we had I had a list side, probably about 1,500, and we did everything for those patients, including visiting to them at home, and they'd come out from surgery. And actually, it's not like that at the moment because the demand has got so high. So what we talk about is actually identifying those most complex patients with the greatest need and making sure that they have continuity of care, which may not always be through one person, but it would certainly be through a team. So the neighbourhood service talks about identifying the people that are most complex and most at risk, and then establishing teams around them. And those teams need to include access to general practice and primary care, but also needs to work out how we better organise community services, mental health services, voluntary services, social care, but also input from specialists for those people so that they don't have to travel. So again, it's that if we started valuing patient time as being our metric assess rather than ease for individual organisations, we would organise ourselves completely differently.
When I hear this, it sounds very compelling, and it sounds like, oh, well, why haven't we done this already? But one of the questions that I've heard also from clinicians that I've spoke to is essentially what happens to the existing incumbent system of small general practices which people have put their lifetime into, of communities that are already being served, and how does that workforce essentially then get packaged?
So this is in addition. So what we're talking about is wrapping around practices to make sure for most complex patients. So what we're seeing over time is a real shift because of rising complexity of patients, because of the joys of technology. So when I started, we had to send people into hospital to start them on ACE inhibitors because we were so worried about renal artery stenosis and that people would faint and drop down. So we had to send people in for an overnight stay. Now, we'll now have people on quaternary treatment for hypertension and not bat an eyelid. So because you've got that absolute, and each time you get a new medicine come in, you can see you've got that shift and that increase of complexity. And that's one of the joys about medicine, is that you're constantly learning and what you're doing is evolving. But that means the model that we had also needs to evolve with it. And because of that rising complexity, I think it is unrealistic to assume that people will be able to be because you're starting then to ask generalists to be more expert across multiple areas. That is unrealistic. So what we need to do is work at a bigger scale and make sure you have got expert generalists for different areas such that people can be supported in a way that works for them. And that's why the connection and the relationship between hospital specialists and GPs is so important. So again, and I keep talking a lot about in the olden days, so when we had fewer specialists, I knew who my cardiologist was, I knew who my psychiatrist was. They knew the cohort patients I were looking after, and I could phone and go, Mr. So-and-so's da-da-da, and they'd go, right, do that. And because you had that consistency of relationship, I was more comfortable with holding risk in the community, and also the consultant would be more happy to discharge into the community and probably put off admission. The other bit we've lost is continuity within hospitals. So again, we used to have the firm structure where you'd have a consultant, you'd be on call with the same people all the time, and I'm not saying the olden days were the glory days, but there were some things that were good and were better. Now you can be admitted to hospital by a team and never see the same people twice. And because of that, I think you get over-investigation and repetition of investigations and lack of clinical accountability to look after people.
When you say, okay, this is on top of existing systems, does that essentially mean that these big general practice centres or multi-care centres are going to then, as they grow, take all the oxygen, and the smaller, less effective ones are going to slowly fizzle and die? Is that the idea?
No, because I would say general practice, which is working via the partnership model, is probably the most effective way to deliver healthcare. Full stop. You can see when you get the right population, the right group of people in the right environment. So estates matters a lot for this. The digital connectivity matters a lot, and the relationships matter a lot. When it works, it flies, and it is incredible. It's not working everywhere. So we haven't got enough doctors, we haven't got enough people that want to work places, we haven't got the right buildings, the general practice estate is not fit for purpose. And what we need to do is try and make sure that we remove the inequity that exists across our country. So core general practice still needs to be delivered. And one of the things we launched some we launched a neighbourhood health implementation programme just straight about the week after the 10-year plan came out, and had 141 applications, so covering 80% of the population of people talking about how they were working in this way. And we've also been running our primary care network pilots for 22 test sites across the country. And having followed those really closely and looking at the applications, there are a number of themes that come out of things that you need to deliver this care in a different way. And one of the most important things is access. But it's access to GP, and it's on the day demand. And you need to get, and practices that have got on top of that, either by, there's some brilliant, there's a woman called Louise Bishop in Colchester who still runs basically rock up at 8:00 and we'll see you. It's just a turn up and see, but it works for her because it works within her model of care. Other people have moved to full triage, using AI triage or using AI phone answering or using risk stratified population, and that works for them. It'll depend largely on whether you're urban, whether you're rural, and depending on the workforce you've got available. So, but GP access and on-the-day demand directly correlates with staff satisfaction, which then gives you the headspace to be able to then go on and start to think more about how you do continuity. So we've got the brilliant practice in West Camden, led by a woman called Rumsha Ahmad, who used to have a waiting time of sort of more than 40 minutes on the phone. So the thing is, we put in cloud-based telephony for all our phone systems across England, so we now know how long people are waiting. So before, you'd get people that just couldn't get through. So initially we had a dip in satisfaction because people then were all getting through, but then they knew how long they were waiting, which I think is it. But actually now you can start tomorrow. You can see these wait times coming down. So Rumsha, your routine appointments were weeks. She had no continuity of care and the call waiting time was terrible. She'd gone down to 2 to 3 minutes call answering. She's got to 80% continuity because she's got the on the day under demand, and wait for a routine appointment is a couple of days. And she's done that by quality improvement and by working with the team and working systematically looking at the data to improve what they're doing.
Mm-hmm. And if we look at a GP practice, there's a fixed amount of patients that a specific doctor can see in a day. And now we see that there's some kind of waiting time. So we're either going to work on, okay, we have a demand. Can we decrease the demand? Or we're going to make it more, the triage system better. So what is urgent, and this is going to get the same day access. So what I'm understanding here is the same day access is going to come for the people who really need it. And then the other patients who have some other kind of questions, are they going to help in a different way? Is that the idea of how you're going to?
Nearly. So
Okay.
When you get on the day demand sorted, and I've heard for the first time as part of these pilot where GPs saying, I never thought I'd say this, but demand is finite and demand is predictable. So what people are now starting to do is to organise their workforce in different ways. So we also found, so the pilots do, they do sort of time and motion studies of everybody in the practice about the calls every 2 months. So what the calls coming in, what the workload is, what the people are doing. They found that 20% of their calls are coming in that relate to activity from secondary care. So people phoning up going, when is my hospital appointment? Do you know what my results are? Do you know, can you expedite my referral? That is why this relationship between the hospitals and general practice is so important. Because actually, if you've got forums and conversations where you kind of go, do you know this is happening? Could you do this? You've taken out a whole chunk of the calls. If you also make better use of things like, we've got Pharmacy First, where people can go to the pharmacy for 7 common conditions and be treated for that company. If you make better use of that kind of thing, and also then, once you've got that on the day demand under control, got your triage properly sorted, you then start to see the impact from proactive care for what that does on the demand. So proper use of vaccinations, proper use of structured medication reviews, proper care planning around the most complex patients. So it's a mix. But number one, you've got to get your call answering under control, because if people you get a demand. The failure of demand drives more demand. So your people will recognise. And if you're sitting doing your clinic and you know you've got 6 people waiting and somebody comes in with 4 problems, I've done this myself. You kind of go, okay, right, I'll deal with that one. send you off some investigations for that, which actually they probably, not whether or not they would need if you had time to do it properly, and then come back. So rather than, and you can see people that have got their demand under control are doing 15-minute appointments, not doing 10-minute appointments or shorter, and they're dealing with things in one sitting and not asking people to come back. And that's what gives you the headroom to actually get on top of things and get things under control.
Mm-hmm. So you want to allocate the specific question to the right person who can answer that question. But then I would expect people that are infrequent users, they are the ones that you want to educate more of, that this is where you can get to.
Yeah.
Because the front door of the NHS now will be more of an app.
That's right.
Where so it can triage. Yeah. What will happen to the people that have complex needs? Yeah. What kind of infrastructures are going to be there to help these kind of people?
So number one, I think the really important thing that the app will enable us to do, and lots of places doing this already, is identify those people who we've just got to see face to face and we've got to look after differently, versus those people that it's absolutely fine to say, go and look at this online resource or go off to the pharmacy. And places that have done, so Frimley have been doing this for years, which is one of our more advanced places, and all their patients are stratified. So I live me and my parents live in the Frimley system. So my parents will be red. So if they phone, it is these are complex patients. You need to have a lower threshold for seeing them face to face and a lower threshold for making sure they've got access to a multidisciplinary team to look after complex needs. My children, who are fit and well and actually would prefer to have an online access or a phone or not even actually talk to somebody but deal with it in an asynchronous way, that's absolutely fine. But so there is the importance of the stratification of the population to identify the people and then making sure you've got a differential offer, to be honest, for people that's based on their need.
I would like to get one question in about the workforce and your vision for the workforce, because we've just been talking about hospital community, but in the context, in the UK at least, there's a shortage of GPs. There's an unhappy junior doctor base or resident doctor base. How do you see the provisions being serviced, and also what's the role of then peripheral carers like nurse practitioners and advanced care practitioners or in providing those services?
So I think medicine is a team sport, isn't it? So we've always worked as part of multidisciplinary teams, and there is that terrible phrase of you've got to work at the top of your license. Actually, some people kind of go, I just want to work within my license, because actually when you're constantly working at the top of your license, that is exhausting, and we do kind of need to be really clear about what people's roles are and how they fit within the team. There will definitely be some generic skills that would help for people to have that would reduce down the load for the number of repeat visits that people need. So my old patch, so in the Epsom area in Surrey, where we set up Surrey Downs Health and Care, one of the bits found sort of the physio going out and being able to measure a frame or deliver a frame for a toilet, or the OT going out and being able to check someone doing their exercises. That kind of just a very simple addition to a skill set reduces down the need for a visit. So there's all that kind of bit with it. I think we've lost respect, I think, is one of the big drivers for people leaving. So one of the reasons why I focus so much on the primary secondary care interface is that there has been, and I have to say it is really improving, but there has been a loss of respect between, in particular, doctors that I think partly came from when we had CCG still, where GPs held the commissioning budget. And so that was when sort of GPs were more set up in opposition to behaviour.
CCGs,
clinical commissioning groups, yeah. So the bit that, the NHS has 3-letter acronyms coming out of his ears, don't we? So we had, primary care groups, primary care trust, to clinical commissioning groups, to ICBs, integrated care boards, to, that's what we do. But essentially it's the commissioning, it's the organisation of the commissioning infrastructure. And so we had we had payment by results, where activity in hospital was paid for depending on what you did, but with the GPs holding the accountability for the purse strings. So that caused tension. We then had, during COVID, we had a real breakdown in relationships we just didn't see each other anymore. And so there's been a loss of respect. There's also, I think, been a loss of respect for how we look after people in our workplace. So a lot of the issues with residents, we've got the 10-point plan to improve working conditions for resident doctors, which includes really basic things that really, as trust us as employers, we just need to sort out. People need to know when their holiday is. They need to know that they're going to get paid. They need to not have to repeat their statutory and mandatory training every time they change placements. We need to make sure there's hot food. We need to make sure there's parking. None of this stuff is rocket science, but we need to do it. And actually, we've now put delivery of our 10-point plan into the assurance and the oversight mechanisms for trust, which should drive it. So I think one of the we need to get back to being kinder to people, being kinder to each other, but I think a lot of it is the respect thing. I would really push.
Yeah. So I hear respect. We have all these sort of benefits of working, making life easier, but I don't hear anything about money. And I know exactly at the moment, one of the big questions is that people feel like they're underpaid and overworked.
Yeah, so I mean, funding is an issue for government. So I'm not going to talk about that. I'm not going to comment on that. But I think that there are many things that are in our gift to make things better, not just for doctors, but for all people that work in all our settings.
Mm-hmm. Okay.
And what I hear is that we're identifying the tasks that can be outsourced to other workforce. How do we make sure the quality is being warranted, and who is going to oversee the things? Because one could think, there are more employees next to the doctor, so the doctor also needs to oversee that. So how do you circumvene these administrational extra work, let's say?
So a lot of it can be digitized, can't it? So if we want to segue into the analog into digital, so there's the use of ambient voice technology that actually would take a lot of those tasks away from people. The better use of so every time we do a referral, we create a task, we create a thing. There are better ways of doing things digitally that takes out a lot of that administrative burden, I think, for people.
Sorry, what's ambient voice?
Ambient voice is this when you talk and it scribes as you speak, and then some of the really advanced systems, what they also do is they identify the tasks, the things that will already fill out the blood forms and are already to do the referral bit. So you can come out of a conversation with the patient with the note fully done, with all the admin bits already done, and all you've got to do is check it, which is really important, check it, and then press send.
Okay, so we're automating, we're digitizing, but for example, when we talked about pharmacists prescribing for 7 common issues, I imagine there would be like ear infections, STDs.
Yeah, well, no, so it's ear infections, it's impetigo, it's shingles, it's really common things. Yeah. So we looked at sort of workload coming in, and they were the 7 most common things that we went for, and contraception and emergency contraception, and they could do blood pressure checks as well.
And who takes responsibility if a pharmacist was to give a medication like a trimethoprim or flunaxazole or something, and they had a reaction?
Yeah, they're professionals, aren't they? So they have professional accountability, and that's the point of it. And they follow the patient group directives, so there are really clear guidelines for when you can give medications. It's the same like nurses giving vaccinations and things. There are really clear clinical governance around how these things work.
I believe these are things are simple enough and limited enough that the risk is mitigated.
Yeah, and people need to go through required training before they can do it. But we sign off. I mean, I've just signed off another whole pile of the patient group directives to make sure that the criteria is really good. And I think non-medics are much better at following algorithms and directives than doctors are.
Yeah. One question that I got from a clinician yesterday would be sort of, when does it stop? Because what we've seen is we see anesthesiology assistants now getting further into the anesthesiology practice and inducing on their own. We see some people in England now doing cataract surgeries who aren't medically licensed. When does it stop, or is it just go until we see the risk?
No. So, I mean, I think I come back to my earlier point is that medicine constantly changes and constantly evolves. If you go back to 1948 when the NHS started, it was largely a doctor and a nurse-led service. We have evolved roles as our ability to do things has evolved. So I would, the NHS is a living, breathing thing. Healthcare is a living, breathing thing, and it will continue to evolve to match the needs of the population and of the workforce.
And the caveats, because this can also pose risks, like if you have a lot of guideline-based things that you don't oversee a complex patient that may have a specific, they may have impetigo, but that falls under a different framework of all diseases. How do we make sure that these other professionals can see these things without having the expertise of the complex?
So that's why you risk stratify your population. So you make sure that your most complex patients are still seen by your GP. So it's like, I would never send my dad off to pharmacy first if he had a cough, or if he had shingles. I would kind of go, okay, let's have a little look at him and see what else is going on. So that's that importance of identifying your most vulnerable patients.
And who is going to identify those patients?
So that's a technological thing. So you look at so when you risk stratify the patients, and there are different ways of doing this, but essentially you look at number of long-term conditions, what's wrong with them. But it's really important to put in, it's not just about physical health. You need to include the social situation. If somebody's homeless, They are naturally more vulnerable. If somebody is frightened, they are naturally more. So people that have experienced domestic abuse are at much higher risk, and we'd have a lower threshold for bringing them in and seeing them versus somebody that is employed and living in a more stable environment. So you put all of those risk factors in and then stratify the population. The most simplistic form is red, amber, green. Some places like in the Southwest, there's a system called Brave AI that updates weekly on different things happen. So if somebody's had a fall or had a thing, that will then up their score and will then identify to the teams that somebody's risk has risen and to go and check out and see what's going on with them.
Then making a full transition now into the digital topic, would you be able to give the listeners a sense of essentially what is being done and what's trying to be achieved?
Yeah, so I think there's two main things. It's the use of the app as the front door for the NHS wherever possible, and that would be things for repeat prescriptions, for changing appointments when we get there, for accessing consistent medical advice about conditions. There's also the making sure we've got a single patient record. So one of the reasons why people are able to do the risk stratification in some places is because they've managed to bring together the records across multiple organisations and share that data. So we've got the federated data platform, which underpins all of this, which means that then we can start nationally to then disaggregate based on different things and making sure we know who those most vulnerable people are, and we can monitor outcomes and can monitor and spot people as they're becoming unwell. So it's a joining up, and again, if you come back to what I said at the beginning about neighbourhood health, making it easier for people and easier for professionals, it's making things easier for people, because it's kind of like start here if you can, and it also frees up for those people that are not able to access digitally. It frees up resources for them as well. So again, if you go back to GP access, yes, there's online consultations and online access, but there's also walk-in and there's also phone, and in England that will be available 8 to 6:30.
Yeah. The context of this, in my knowledge, is interesting because in 2000, under Tony Blair, there was also a idea of central digitalisation.
Yeah.
And £12 billion later, it was called one of the worst disasters of all, maybe the last 20 years. What's different, and have we learned lessons?
Well, you look at what we've got, actually. We've actually got an awful lot of digital infrastructure in place. So, you look at general practice, we've been digitised for a very, very long time. So, GPs do not use paper at all. I mean, that's a fully digitised system. We send prescriptions electronically to community pharmacy who receive them. Nearly all of our trusts are now on electronic records. So I think I think you have to be careful about hyperbole with these things, and there will never suddenly be overnight be perfect. What you do is the change is incremental, and it's a Chris Whitty thing. He always says, when you're in the NHS and you look at it, you think nothing's happening, but when you look back 10 years ago, oh my word, look what we've done. Yeah. And I think that's a really good example of if you go back to when I started, I was on Lloyd George handwriting, didn't have a mobile phone. We're a million miles away from that.
Yeah. And who's going to deliver it? Is it going to be outsourced privately? Is there any idea about, is it going to be an internal development? How would this big digitization project be actually realized?
Well, it's ongoing. It's not going to be. It is. We're in train. So we have a big NHS England transformation directorate here that leads all of our digital transformation and runs an awful lot of live services as well.
Okay. The train's left the station.
Yeah. No, we're well on our way.
Well on the way.
But it's you never arrive at your destination, because again, it's this thing that technology improves and is relentless.
Yeah.
So you keep going and you keep evolving. I learned a long time ago that it always feels like this.
So it's the journey that counts and not the destination.
Well, yeah, but you're always on it. You're never going to get there, because we're always going to be developing new products and new medicines and new things that you can do. So you will never get there.
Yeah.
And if you think you have got there, you've got it wrong.
Well, for the digital, you're never going to get there. But of course, the patients want to see some difference, right?
Yeah.
Is there, what are like the milestones? What are the things that you're like, okay, in 3 years, this is what the people are going to expect?
So, if you come back to the app, it's that you can book your appointments on the app, that you can change your appointments on the app, that you can access your record on the app, that you can order your prescriptions on the app. That'll do.
Yeah. Okay. Mm-hmm. One last question about, you mentioned a few times AI and how it's going to be integrated into care.
Yeah.
How does that work with the companies, the ownership of the data, the licensing? And I imagine when I look at it now, most effective AI companies are across the sea and not built and owned in Britain. So how are we going to
Yeah, so
do that?
again, there are people much better at this than I am that assure me that the clinical governance around this and our ability to keep data safe will be ensured. So it's one of those, I could make a half-assed go at it, but I'm not going to because it's too important. But, there are many experts looking at this and giving this a huge amount of thought.
The third part of the episode today, we're going to be looking at the idea of the sickness to prevention as a core model for the NHS. Can you describe exactly what that is?
So it's the shift from sickness to prevention. So at the moment, we have a very medicalised model where we're very reactive to people's needs and rush to give them medicine or to put in place a transactional intervention. We have talked about doing more prevention all of my career and all of probably everybody else's career. And it is that real commitment to doing this properly. So our CMO, so Chief Medical Officer Chris Whitty, has made a commitment to reducing premature mortality from preventable cardiovascular disease by 25%. That's huge. Reducing down the number of strokes, reducing down the number of heart attacks of the population will have a material impact. If we're going to do that, we've got to be really serious about prioritising prevention. So the bit, I think when the people talk about this shift, we do tend to over focus on things like secondary prevention and cardiovascular mortality. But actually, it's really important to remember the primary prevention bit, which actually is so you can see some of the big things that going through relate to sugar tax, relate to the vapes bill, relate to some of the more legislative changes and actually our approach to obesity and the new obesity, the meds that come out. But I think in terms of prevention, the one bit we never really give enough credit to is vaccination and screening. So our vaccination program is a thing that if everybody was vaccinated against flu this winter, we'd have a material impact on the number of non-elective admissions and reduce the number of deaths. And we don't talk about that enough.
Mm-hmm. It's brilliant to prioritize prevention. And at the same time, we still have this urgent reactive care that has some kind of waiting times that exist. How are we going to mitigate that? Are we going to allocate more finance just to make sure that crimps and then continue with prevention?
It's a bit of a mixed model. So at the moment, what we're doing is we're unbundling the UEC block. So what that means is at the moment, during COVID, for very necessary reasons, we gave organisation blocks of money to deal with the activity because we weren't quite sure what was happening or how things were escalating. That has led to probably money being in wrong places. So over this winter, one of the things the team here are doing are looking at how we break that down to make sure we pay for the activity in the right places. If we can then hold growth, so each year government allocates money via the spending review process so that we know how much money we're going to get. If we can hold, and within that there's growth factored in so that the pot of money coming out will get gradually bigger over the 3 years. We unbundle block, we make sure the money goes where it should be. The way that we invest in the prevention is by by stopping the growth in non-elective demand and investing that growth money then further out into services so you start to make the left shift of funding. So it won't be immediate, but I, for the first time, can see a mechanism through by which we've got a brilliant finance team who are doing some really complex thinking and work on how you do that. So this for me, for the first time, doesn't just feel sort of people sitting around going, this is a really good idea. This is backed by finance team and by trusts really understanding what it is we're trying to do.
And how does that then, as Christiana referenced, the large waiting lists that already exist, is it just that we're going to be spending the money more effectively, or that the load's going to be taken now into the peripheral and the small surgeries are going to be taken off and that load? How does that work?
So if you look at, so that's talking a little bit about, so the urgent care demand, so that we need to get better at doing our proactive care piece. So that's identifying our cohorts that are most likely to go in. The waiting list is it's a different issue, and there are different responses to it. So 80% of the people on waiting lists are waiting for outpatient appointments. Yeah. So, and there are things that we need to do different. We need to make sure that everybody that's waiting actually should be having that surgery and that they're fit to have that surgery, or that they need to be seen. I'm still not quite sure why anybody with a long-term condition would be under a hospital, because actually what you need to do, I would say, is actually, our plan will be that actually you will have hospitals again linked out to GPs who can provide specialist support to support people with long-term conditions out in the community. People with multiple long-term conditions will then work with them. And that's, again, that identify that cohort with multimorbidity, the most frail people, and put a plan in place around them. So again, my dad, 8 appointments in 5 hospitals. Let's work out which are the important ones and which ones actually we can do in a slightly different way by getting some advice in rather to do it. So there is you reduce down the non-elective demand by building up the proactive care, which is what matters to you, personalising care for people. And then you also deal with the elective demand by dealing with the referrals differently. So we've got advice and guidance, which actually is for transactional things, works really well. So if you've got a technical question about something you don't understand as a GP, you refer and get the response back in, usually within 48 hours from most places. We're also looking at referrals coming in that don't need to be seen by hospital and might be able to be seen by a GP with an extended role, perhaps in conjunction with a specialist consultant looking after them, but again, in the community. And the other thing that we're looking at is a terrible acronym called PIFU, which is patient-initiated follow-up. So most people will be familiar with people with long-term conditions are like, come back in 6 months, come back in 6 months. Those 6-month appointments never coincide with an exacerbation of that long-term condition. So the shift is, look, discharge people with long-term conditions, make sure they've got open access to come back. But that's quite a significant upheaval in the way consultants' job plans are organised to make sure you've got those capacity for those PIFU clinics to bring people back in when they need it. So this is a really significant rewiring across the whole system.
And this proactive care needs a different workforce. So there's money being allocated to this kind of like...
So I think it's the same workforce, just working in a different way.
Okay, but the situation that exists right now,
yeah,
we try to change it, right? Because you just mentioned there are people that may not need to be in the list. So somebody has to go to the list and check that.
Yeah.
So who's going to do that?
So we've been doing that for a long time, and that's around the waiting list initiatives and things that trusts have been doing about looking at making sure everybody on the list that needs to be there. The proactive care piece, a lot of commissioners have actually worked with their local population to make sure people have got more time to have those conversations. And there are bits that support that in terms of sort of structured medication reviews, in terms of so in general practice, we've got the additional roles reimbursement scheme, the R schemes. And a lot of those roles actually support the proactive care. So a lot of these things are already happening and already in place. What we've got to do is make sure that the building blocks are there for everybody to enable them to do that. And then we've also got to make sure that those people have been doing this for years and they're flying, that we don't stop them. And we make sure we carry on giving them the freedoms that they need to keep evolving the model of care and making it better.
Mm-hmm. So we're doing it, we identify what works well, we make guidelines,
and then we spread it. Yeah, exactly. And then you bake in the bits that you know, which is why it's so important having had all of these applications for the test site, because actually you then start to get the themes of like the really successful people, this is what they're doing. Everybody else, you need to do these things.
Mm-hmm.
And then we'll keep working with those sites. Okay, so now what they're doing, now what is the bits that are working?
How are we going to motivate these people to do that?
Oh, so the people people go into healthcare because they want to make things better. The things that demotivate them is not being able to, and the blocks that are getting in the way. So the way we're going to motivate them is make it easier for professionals to deliver care. There is nothing more rewarding than having somebody in front of you and being able to make it better. So the way we're going to motivate people is by enabling them to help people and make it easier to deliver care. The bit we have to do is make sure, so one of the things that really works is bringing teams together almost in the same room to actually sit and work, but also to have conversations about how they want to deliver care. And partly because of COVID, partly because of the complexity of the system, because people don't know each other anymore, they don't know who to talk to. So there is a real organisational development piece to do about just bringing people together again.
And in the chapter 5 of the operational model of the 10-year plan, there are some points on financial motivation to ensure that quality is being safeguarded. How is that going to be in place?
So we've got modern service frameworks that we're working up. So we've got 3 this year. I'm going to get these wrong now. There are 3 modern service frameworks coming out this year. One on cardiovascular disease, one on sepsis, and one on serious mental illness. And 2 of those will be out in March. The serious mental illness one will be out a bit later on in the year. And we've got a pipeline of things coming through. And those modern service frameworks will describe best what we're currently doing, the gaps, what we should be commissioning and what outcomes we should be looking for and working for. So that'll drive, and they'll be signed off. So we've revamped the National Quality Board. So Penny Dash, our chair, did a review of quality across the NHS around the same time that Lord Darcy did his review. And through the National Quality Board, we'll start to go through and make sure we've got modern service frameworks or examples of best practice that will support the shift from integrated care boards to becoming strategic commissioners. So let's give them the tools they need to commission properly.
So one of the really interesting parts of the plan that captures my attention is the operating model and governance changes that you've proposed.
Yeah.
And what I read was that systems are going to be reviewed, and when they do well, they're going to be reinforced positively, and when they do badly, they're going to have some sort of intervention. Can you describe that so that I can understand?
Well, that's not new, actually. We've always done that.
Yeah.
So we've always had support for organisations and systems that are in more difficulty. So it's the provider support regime that we've always had. But at the heart of it, it is making sure we're delivering cost-effective, safe, high-quality care for the population. And it's driven through outcomes. So we've got a national oversight framework that looks at measures for trusts, measures for integrated care boards, and also measures for community mental health ambulance trusts and general practice. And we have a regional infrastructure. So the regions look after their integrated care boards. We've got 7 regions. We've now got 25 integrated care boards that cover a set population, probably all about more than 2 million now. And the regions will hold the integrated care boards to account for the national oversight framework, but people will have things that matter to their local population depending on their geography, demography, topography that they will also monitor locally. So it is one of the we're the 5th, 6th biggest organisation in the world, the NHS, but we're made up of multiple different organisations within it. But this is one of the things that we can do with an ability to centralise, is make sure we're driving up the quality of care in a consistent way across the whole country.
The last question that I have is, when reading independent analyses of this report from the Commons Library, the Nuffield Trust, the British Medical Association, the NHS Confederations, the common theme is, hey, look, this sounds really great, but we're really worried about delivery on some key themes, which would be, hey, look, this is a nice vision, but it's just the 2019 long-term care vision plan repackaged. There's not enough money. There's 29 billion, but that's not enough. The views on the workforce that we've discussed a little bit aren't realistic. Other critiques are, maybe referencing last night, I had a conversation with a general practitioner, and she was like, yeah, look up there, they're just rearranging deck chairs. And at the end of it, we're still going to be able to see the sea, and it's just the same. This is a big, broad criticism that I'm proposing now, but what's your response to these reports and these analyses?
Well, people always say that when anytime a new report comes out, that's kind of it's very easy, isn't it? It's very easy to criticise reports. I would say sitting within this and seeing the amount of work and effort that's going on to delivery, the infrastructure that's out there, and actually, I spend a couple of days a week going out visiting systems. I can already see the delivery, the plan that's out there. And the plan, because it was based on so much engagement out into the systems, it's based on, there was nothing in the plan that somebody isn't doing somewhere. And what the point is that we're trying to do is create the conditions for success for everybody to be able to deliver the best care. So, it's very easy for us to be cynical. I would say, please, let's join together and actually work together to make this better. This is so important. I've got colleagues, we're all of an age now, why are you putting so much effort into, well, we're going to need it soon, aren't we, ourselves? So it's sort of we are all determined to make this as good as we can. But I think my point is, there is nothing in that plan that isn't happening somewhere anyway.
Yeah.
So let's make sure we spread it. I was on a panel with the chap that runs Kaiser Permanente in the States. And you kind of see they've got the infrastructure they've got there is all the stuff we're striving to do. They've got really good estates. They've got joined up digital. They've got joined up patient records, and they've got governance that's easy to pull a lever and things change. You can see what the enablers are that we need to do. But he said a very interesting thing. He said, people in America are always really, really positive. And so that makes them, he says, it makes them appear less intelligent. People in England think that by being cynical, it makes them look intelligent. And his view and my view is, well, no, let's actually be realistic at what there is. The plan, it is a high-level vision, but it is really important that the NHS is a fabulous thing. I'm so proud to be part of the NHS. I'm so proud that my career has been within the NHS for the whole time. It's not perfect, but we are making it better, and we will always continue to make it better.
And then for a clinician, they say, okay, I'm buying in. I love the idea. And they say, okay, in 3 years, 5 years, 10 years, what would I look at that says this is a success? How would you say this is working? We're doing a good job. What's that look like?
So 2 measures for me that really, well, it's 3 things really, but 2 measures: patient satisfaction. So we routinely measure patient satisfaction, both in hospitals and general practice. I would want the patient. We do a social attitude survey as well each year, which has been on the decline. I would want to see that was going up. So number 1, does it feel better for the public? And then number 2, does it feel better for the staff? So let's look at our staff survey results and let's make sure those are improving. And then let's look at continuous drive. The other 2 metrics that are less important than those 2 relate to quality and then relate to access targets as well. But those are the things we've just got to be relentless on. And staff, don't underestimate the importance of the staff survey. If you have got people that feel respected and are happy where they work, the quality of the care naturally drives up, and patients are the best way of judging whether or not the services are working.
To finish off, looking back on your career, what's the favourite mistake that you've made?
Oh, that's a great question.
And then to finish that off for the listeners, what advice would you want to give off or leave them with?
Yeah, so I said favorite mistake you've made. Well, so I mean, we make mistakes every single day, and it's its ability to change it. So I've got a recent one actually, which is this. I have changed my mind on the importance of GP access underpinning the whole model of care. So I used to think that actually you risk stratified, you do the proactive care, and everything falls into place. That's wrong from the evidence. We've now got the PCN test, and actually, so that's a really recent one. There's any number of things that are wrong, that you keep learning from. But I think the bit I would take away is, if you ever think that you're done and you've arrived at destination, you are wrong, because you've missed the next thing that's coming along. And always keep looking for that next mountain that's over the hill, the next thing that's coming along, but always create the conditions for success such that you can receive and rejoice in the next ability to make things even better.
Then I think we'd like to thank you enormously for your time, Dr. Fuller, and for sharing your thoughts. And
thank you very much for having me.
It was a pleasure to talk to you.
Thank you.